Hello everyone. So in this session, I'll discuss all the high yield points and some important concepts related to gynae and obs. So let's start with the infection in pregnancy first. So the first condition is asymptomatic bacteriuria. In this condition, patient is completely fine, but the urine analysis of the patient is positive for nitrites and leukocyte E stress. So in this case, we give nitrofurantoin to the patient to avoid PID. Even though the patient is completely fine, there are no symptoms in this condition, but still we will give nitrofurantoin to the patient to avoid PID. Second condition is pyelonephritis. Pyelonephritis is upper UTI in this kidneys infected in patient present with fever, vigor, chills, nausea, vomiting, and along with it, patient will complain flank pain and flank tenderness. For the diagnosis of pyelonephritis, we do urine analysis and urine culture, and for the management, we do inpatient management in this case. For the pyelonephritis, we do inpatient management and we give appropriate antibiotic according to the results of the culture. Third condition is endometritis. The word itself suggests that there is infection of the endometrium. So, due to the prolonged rupture of the membrane and in the cesarean section, when the endometrium is exposed to bacteria for longer time, this results in infection of endometrium called endometritis. It presents with fever, uterine tenderness, and foul-smelling lochia. And for the treatment, we give clindamycin and gentamicin. We can remember this as ECG, E for endometritis, C for clindamycin, and G for gentamicin. Similarly, due to the prolonged rupture of the membrane, sometimes chorion and amniotic membrane gets infected, which results in chorioamnionitis, means infection of chorion and amnion. It also presents with uterine tenderness, purulent cervical discharge, and fetal tachycardia. For the treatment of chorioamnionitis, we give ampicillin and gentamicin to patient. But due to the fetal distress, as we already read that fetus will have fetal tachycardia will be there, so we do urgent C-section in this case. In case of chorioamnionitis, we do urgent C-section regardless of the gestational age, whether the fetus is 34 week or 37 week, it doesn't matter because fetus is in distress, so we have to do urgent C-section or urgent delivery in this case. Alright. After that, this is a superficial wound infection. This is basically cellulitis. In this case, there is wound induration and erythema, and for the management of superficial wound infection, we give cephalexin to the patient. Then, breast-related conditions like mastitis. Mastitis is infection of breast. It presents with fever and pain in the breast. And on the examination, there is tenderness and erythema. And for treatment, we give doxycycline to the patient. So for asymptomatic bacteriuria, we give nitrofurantoin. For endometritis, ECG, clindamycin, gentamicin. For chorioamnionitis, we give ampicillin, gentamicin. For superficial wound infection, we give cephalexin. For mastitis, we give doxycycline. Now, breast abscess. Breast abscess has similar clinical features as mastitis, like it presents with fever and severe pain, but two features are different from mastitis, like in breast abscess there is fluctuant mass and lymphadenopathy, and for the treatment we do incision and drainage and give the appropriate antibiotic according to the results of the culture, or we can give doxycycline as well. Then secondary syphilis. Secondary syphilis is basically an STD, right? It presents with maculopapular rash, which involves palms and soles. And for the treatment, we give intramuscular penicillin. We know that in tertiary syphilis, we give intravascular penicillin. But in secondary syphilis, which presents with maculopapular rash, we give intramuscular penicillin. And now, Group B, streptococcal infection. Group B streptococcal infection is very common in pregnancy, so we give ampicillin and penicillin prophylactically 4 hours before delivery to almost every mother. If mom has a history of genital herpes, then we will give acyclovir therapy 8 or beyond 36 weeks of gestation till birth. Even though if the mother is completely asymptomatic at the moment, she doesn't have any symptoms of herpes, no current lesions, but still we give acyclovir 40 because she could be shedding asymptomatically, so we give prophylactically acyclovir. And now the second topic is vomiting during pregnancy. So we all know that vomiting is very common during early pregnancy, and it's mild with no other symptoms like abdominal pain or tenderness. And for the management, we recommend mom to change her diet and give pyridoxine. This is all the management of first trimester vomiting. But sometimes what happens is there is severe vomiting in second or third trimester with other symptoms like right upper quadrant pain and tenderness. And in this case, we need to rule out other causes like cholecystitis, which is common in pregnancy. So to rule out cholecystitis, we need to do ultrasound if patient is presenting with severe vomiting. Alright. Then this is hyperemesis gravidum. In hyperemesis gravidum, it is severe and persistent vomiting. In fact, it is so severe that it causes dehydration and electrolyte imbalance. What kind of electrolyte imbalance? Like hypokalemia, hypochloremic metabolic alkalosis, and hypoglycemia. So there is 5 to 6% weight loss in this condition. And sometimes hypoglycemia is so severe that it can result in ketoacidosis and ketoaciduria. So we need to check ketone level in urine if we are suspecting this condition. So for the management, we do inpatient management in the case of hyperemesis gravidum, and we do IV antiemetics and treat fluids and electrolytes, and also give thiamine if there are signs of Wernicke's encephalopathy are present. Like what are the signs of encephalopathy? Like horizontal nystagmus and ataxia. So this is all about vomiting during pregnancy. First trimester, mild, it's completely fine, nothing to worry. Just manage conservatively. If you are suspecting any other emetology like cholecystitis, then we need to do ultrasound. And third one is hyperemesis gravidum. This is a severe condition. We need to admit patient and do inpatient management and replace the losses like electrolytes and fluids and thiamine, all this. Then hypertension in pregnancy. This is very important topic. So gestational hypertension is defined as systolic blood pressure greater than 140 and diastolic blood pressure greater than 90 after 20 weeks of gestation. There is only one condition in which preeclampsia is present before 20 weeks of gestation, that is herediform mole. In herediform mole, preeclampsia is present before 20 weeks of gestation. This is the only exception. So why this happens? What is the pathophysiology behind it? It is caused by the abnormal invasion of the cytoplasm in the spinal arteries. This is the pathophysiology behind it. So we define this gestational hypertension is blood pressure greater than 140 over 90. So now preeclampsia is hypertension plus proteinuria. So what's the range of proteinuria in preeclampsia? It's basically proteinuria which is greater than 3 grams per 24 hours or protein to creatinine ratio greater than 0.3 is known as proteinuria. This is the range of proteinuria in preeclampsia. And preeclampsia present is either mild or severe. And features of severe preeclampsia are like severe hypertension, which is blood pressure greater than 160 over 110, headache with visual disturbance, and epigastric pain with nausea and vomiting and increased knee reflexes. These all are the features of the severe preeclampsia. So, in preeclampsia, there are increased chances of placental abruption, which can lead to DIC as well. So we need to manage it carefully, and we need to do inpatient management in case of severe preeclampsia. Preeclampsia is also associated with other conditions like pulmonary edema, sudden visual loss, and subcapsular hematoma in liver, which present as epigastric pain. In fact, it presents with severe epigastric pain. Now, HELLP syndrome. HELLP syndrome is associated with the preeclampsia. It is HELLD. The word itself suggests that there is hemolysis, elevated liver enzymes, and low platelets in HELLP syndrome. In eclampsia is basically same as preeclampsia, along with one other feature that is very important, which is generalized tonic-clonic seizure. And each seizure episode lasts for 4 to 5 minutes at least. For the management, we need to treat hypertension and seizures both, and we have different drugs for the treatment of each. For hypertension, we have 3 options. First line for the treatment of hypertension is IV labetalol, and labetalol, you all know that it is alpha and beta blocker. Because it has a beta blocker effect, so we need to avoid in bradycardia. In that case, we will give IV hydralazine. The other drug is oral nifedipine. It's a calcium channel blocker, and we give it orally. It should be avoided in case of vomiting. And now for seizures, we give magnesium sulfate. What's the mechanism of magnesium sulfate? Magnesium sulfate is basically a neuromuscular blocker, and it increases the seizure threshold. So this is the mechanism, and as it is a neuromuscular blocker, we have to avoid in the case of myasthenia gravis. We cannot give magnesium sulfate in the myasthenia gravis patient. Sometimes magnesium sulfate causes toxicity because we give in loading dose and then maintenance dose. So before giving the maintenance dose, we need to check certain things like urine output, knee reflexes, and respiratory rate in patient before continuing the loading dose in patient. What are the signs of magnesium toxicity? Signs like areflexia, decreased urine output, respiratory depression, and cardiac arrest. These are all the signs of magnesium toxicity. And for the magnesium toxicity, we give calcium gluconate. This is an antidote for magnesium sulfate.